Welcome to another episode of Out of the Fire podcast, where we get into all kinds of topics that have something to do with healthcare, fire interoperability, technology, data, and everything else in between. And today I am so glad to have Jill DeGraff on the show. That is a true visionary and expert in the area of interoperability. If you've been listening to different voices in this space and you have not come across Jill's takes on issues and positions and regulatory new developments, please follow her.
Well, first of all, thank you so much for having me. This is great to begin our, have another one of our chats. I usually will follow the conversations that are happening on LinkedIn and add my comments or put some articles out there. And occasionally as well, we'll have more formal blogs that are on the icanbewell.com website.
Yes, great. I wanted to start, Jill, with, first of all, a full disclaimer, you are here on your own, not necessarily representing BeWell, as I've also used to work at BeWell. So we're going to try to take a kind of like an industry view of things, not necessarily from one organization perspective. But basically, Bill, you started out, you have a fascinating career. I looked over your LinkedIn and all the different things you've done, and it's just like incredible. And my own personal experience, like in the last couple of months, I took my first stab at consulting in the first time in my career. Over 15 plus years. Just wanted to get your take on people doing consulting and transitioning maybe from like full-time roles versus doing consulting, and what are some of the things that you would recommend and help people to be great consultants and to try that?
Thanks. That's a fun way to start. Well, so a little bit about me is that I've been a practicing lawyer for many decades, but I started as a bank regulatory lawyer and then a transactional lawyer for banks. And then it migrated into a couple of other flavors of corporate finance. And then there was this thing called the internet and e-commerce. This is really dating me. So in the earliest days of the internet, I was there first as an outside transactional lawyer and then in-house. And then after, raising babies and things like that, and I wanted to get back into my professional identity, if you will. We had the big 2008 financial crisis, and we had out of that the High-Tech Act as part of the American Recovery and Reinvestment Act. And we were really like focusing on, the beginning debates of the Affordable Care Act. And from my standpoint at that time, as a consumer of healthcare, of health insurance through a small business of our family business, I was inflamed by what I called the inequities of the health insurance market. I said nothing radicalizes small business more than those inequities, because we were experience rated and we had to pay through the nose. And, there's just a lot of more scale and therefore more competitive pricing if you were with a large company. And so from my standpoint, I'd hear a lot of the partisanship, but then I actually, because I have insomnia and things like that, I would actually go in and read the bill and then the act and follow the regulations in a lot of detail. And, as I went through it, I really started checking the boxes of things that were, through my lens, what's good for me. And I decided I was going to move into healthcare for my professional identity because boy, it's complicated. It's going to hold my intellectual curiosity, but no one person can know it all. And so it's a team sport. I like the idea of team and collaboration and bringing something to that team, like being a specialist, right? And then also just recognizing there's a long tail here. Like this isn't going to move fast, but there's enough of a runway here that a lot of us are starting fresh and starting new under a new regulatory regime. So let's all get in on it together. So I guess my first, and there's some other pieces that I can get into, but I think to answer your question, the first thing is really finding that area of intellectual curiosity that lights you up, that makes you want to keep digging in deeper. For me, that particular tale was going back and doing some continuing education. It was 18 hours of education on the sort of a survey of health law. And I realized I was a sponge for everything. And if you can imagine, finding yourself being intrigued by the 3-day rule under, Medicare coverage for skilled nursing. I mean, there you go. That's number one, like really being intrinsically curious and wanting to see how it all starts fitting together from a regulatory and a business incentive and how can people, how can you actually move to outcomes that matter to you, that you can then, as a consultant, be able to help people see that picture and get from A to B. That's a really enriching thing. And the other part around being a specialist or a consultant, and this really came up further down in my career, but before Be Well, is that, companies can take a risk on you almost on a fractional basis, because they're not making the full investment of a full-time hire. Instead, you get to prove yourself with a small engagement that may expand into something else. But if not, and it's not the right time for any, there are a lot of different reasons. I call it dating, you just move on and you build your network. And really having that growth mindset allows you to end up integrating so many different and varied points of view that ends up making you stronger. And then I guess the third thing is, wow, when you decide to hang up your own shingle, you are really putting yourself out there at risk. And frankly, there's nothing more scary, but there's nothing more exhilarating when you have success, because it's you. And that's thrilling.
Yeah.
But it's
And I
hard.
feel like there's a lot more, not that like you don't need credibility or you don't need to present yourself in a certain manner when you're a full-time role, right? But like when you're in the consultant, I feel like that's even heightened to a level where, yes, you're being looked at as a true, advisor and to delivery, obviously, depending on what is the work that you're doing. But I feel like it is different. Like I definitely I think I enjoyed it tremendously, and to, kind of like offer your take as almost like a neutral party in a way to your, the client that you're working. But great. So okay, so let's move on to the most, I guess, depressing topic at hand right now, which I think I'm seeing like 5 posts on LinkedIn per day on this new CMS framework, interoperability framework, right? That's what it's called. And it's all kinds of different takes, right? You have people from one side that are like, what is this? Yeah, the other people that are like, oh, this is super exciting. Let's go. I'm somewhere in between, I guess. I'm just like, I'm ready to sign up, and like, where do I drink the Kool-Aid and subscribe to the newsletter and all that good stuff? So Jill, can you give us like a brief overview of like, how did this come about and what does it truly mean?
Yeah.
And then maybe we can get into the specifics. I know there's a lot of different things about it, but like maybe we can get started with just like your take
Yeah,
on.
sure. Well, I'll go with that really immediate thing. Then I'll sort of dial back to a little bit of more historical context, and then we'll get to some of the substance. I think that's how my thinking is going to go. I mean, I think this all came together in some respects very early, but it also feels like a continuity in the near term of many of the messages that have been coming out of HHS leadership since the beginning of the second Trump administration. You heard Dr. Oz communicate that, for a health program that covers more Americans than any other health program, we're not getting our value, and that we're going to go bankrupt, and that there is waste and we need to do something better. Right. And we saw really critical hires like Chris Klump heading up Medicare, being the Medicare administrator. And we can get into, how payment policy is being upended in a new, fresh way, one could say. But those are really important pieces because they're really speaking in terms of a crisis that's happening. And even Secretary Kennedy speaks in terms of a crisis involving the disease burden on Americans, and that why are we spending so much money without getting our money's worth? And I'll just say, this particular framework, which was launched last week at the White House, is really just part and parcel of doing all that with a sincere impatience for doing things in that slow, iterative, consultative, consensus building way, because that's been going on for a long time. And we've all been talking about similar things really since the Cures Act was first passed in 2016. We are 9 years in. It's not unusual for a regulatory framework to not get its gears meshed and rolling in full cylinders after a long period. It was true with HIPAA. I mean, HIPAA was passed in 1996. We didn't get rules until 2003. We didn't see an update to it until 2013. I mean, and frankly, this current group is impatient with seeing real results. And they are actually looking at the fact that we could be going bankrupt as our demographics age, as we see physician shortages. I mean, something different has to happen.
And I don't think that's like a partisan issue at all. I think like most people probably understand that to different degrees, but like I think that that's not even the point of debate at this
Right.
point, right?
Right. I think that's right. I mean, I think we can also, for all of us that are familiar in this space, we've always understood that interoperability had bipartisan support. But how are we doing? I mean, are we really holding ourselves accountable to how effectively we have moved to interoperability in the 9 years since Cures Act has passed? Back when the Cures Act was passed, there was already a concept of RESTful APIs. There was already a concept of moving to open interoperability standards. There was an idea for a trusted exchange over a network of networks, right? This is language coming out of the Cures Act. But there were fateful decisions that were made along the way that slowed us down, candidly. I mean, if you'll some of the folks that are listening will know that when the Cures Act, when HTI 1 was proposed initially, former national coordinator Don Rucker wrote a spicy comment, which was basically saying, why on earth are we putting all our eggs in the basket on legacy infrastructure and standards, which is to say IHE and exchange of documents using the CCDA structure? Why aren't we moving to FHIR? And things have been, and also why are we only persisting or prioritizing treatment? Like all these different things have really slowed things down. And there were tactical decisions, but when you start looking at those tactical decisions, maybe incrementally they made sense. We could make that win. We could go live on TEFCA. We can at least start with treatment, and then we can expand from there. Where are we with FHIR-based interoperability? And because everyone understood healthcare is it's a lagging industry. It's not a leading industry for innovation. And so the fact that we were taking so long to adapt and make investment in modern architecture is, I think, what's making this leadership at HHS very impatient. And so I've called in the LinkedIn article or comments, but this is really a race to the top. I can't claim credit for that. There have been a number of people, Anish Chopra, people in Care and Alliance have been talking about the race to the top. Meditech, others, big established firms have been talking about the race to the top, but we need the collective will to make it happen. And CMS is a great convener to do that. So I think the most critical things that make this more than TEFCA 2.0 or worthy of skepticism that we've seen this film before is it's really indexed to a number of key changes that require investment in modern architecture to participate.
Okay. Yeah.
I mean, I'm curious. Do you agree?
Yeah. I mean, it makes me think, like almost like, is it just like such a hard problem itself, or is it just that we have not taken the right steps to fully get on that train? It's almost like you could talk about other great transitions. Like you brought up the internet before, big transitions when you have some new technology that you're adopting, and that transition takes a long time. But then it's something that is, the benefits of it are clear. So the adoption is basically driven by the market demand, and it's, I don't know. Do you feel like there's been things that, like using analogy of the internet, right? Like it was born out of the Defense Department, but then it was kind of like discovered the benefits of it, and then the market took over. Using that analogy, is this going to help us get kind of to a similar place?
Oh, I think that's a really interesting idea. I'll tell you, the original rules when the Cures Act regulations. So I always say that the Cures Act basically put a marker in meaningful use, declared success on the digitization of records, but now we are moving to the interoperability of records. And we are going to do it on open standards. And really, that is a theme that everyone, bipartisan support, broadly advanced by Don Rucker and Seema Verna during their leadership at HHS. And the regulations were also implementing an executive order that was basically saying there will not be, we're going to break down market abuses that based on, competitive moats around data. I can't remember the exact language. I've used it before, but there was an executive order that was basically saying we're going to be doing this on a pro economy, pro competition, pro innovation basis. To me, again, it'd be interesting just to kind of come up with that tracing of the chronology. But I do feel like, and I think Brendan Keeler wrote it really nicely in his blog post over the weekend. It's about competition, baby. Like the markets bring their own incentives. And so what that means is that we implemented in a way where like APIs, FHIR-based APIs, certified APIs are not enforced. Like, we Gene and I have a long history in understanding these issues about how hard it is actually to establish a robust, reliable network of connections through standard APIs that are mandated. But too often, I think people have approached the certification program as a check the box compliance item. There's never enough detail. It's a floor. There's not been the race to the top. How do we be better? And likewise, once you make with TEFCA, this is going to be the floor. We're going to start and try to iterate and get to scale for treatment required purposes over IHE CCDA standards, old standards, and then we'll iterate beyond. When you make those kind of incremental decisions, you tend to get stuck. That's what we see.
Cautious reluctance, checkbox compliance.
And where people are still behaving rationally according to their interests.
Right. And are following the law, maybe sometimes to a T, right? Like, so it's like, we're not going against what's been mandated, but we've discussed this before where even sometimes where people go beyond what it is, like this with the US CDI version 3 adoption by Epic. And then you still see it's like, there's different things that could be done better still, even with people that are participants that are they're all signed up to the mission. Or as they say, a lot of times, supposedly they are. So I think that
I would say this other thing, though, that's interesting. And I think, again, when people are really trying to sort through the noise and the signal here, and is this really different? Because people do need to know, is this really different? Because it's going to impact investments that they make, decisions that they make for their organizations. It is basically saying all the pieces are in place to get to value. Are we aligned? Can we execute together? Can we measure our progress against results and be accountable to one another? A pledge, and it's really important, as you start hearing words filtered out from the room or listening to the live broadcast from the White House, it's a moral commitment. This is not just check the box compliance. This is a moral commitment to be better, right? And some people are going to take that really to heart. But I'm also going to say, I've got to go find this article that hit my stream this morning, but the Wall Street Journal wrote another piece that was talking about how so many of the health plans are going to be exiting the Medicare Advantage business. And let's all recognize Medicare Advantage has been hugely profitable. It has had a rate of growth exceeding the cost, the rate of growth on Medicare fee for service, which is counterintuitive, let's just say. But when I think about why, and I don't have inside information on this, but when I think about why health plans are getting out, I think it's because it's just too costly to be accountable in a Medicare Advantage plan. They've been able to keep raising their rates. They have an MLR. They're able to do risk adjustment, chart chasing, to code to different levels. All those practices have been incentivized because they haven't been checked, but now they're going to be checked. Well, now you got to think, can I actually operate profitably in this business? And my take as it interplays with interoperability is if you have invested in modern architecture so that you don't have these siloed monoliths within your systems to run your business, if you've actually moved to, standardize once and then use it for use your data on a multitude of applications, solutions, and services, and allow that data to move real time, and then leverage what's happening elsewhere in our industry, which is to move towards uniform quality standards, and then FHIR-based API, FHIR-based reporting of digital quality measures, like all that kind of work. If you've already done that, you're going to be very profitable and you're going to grow your business in Medicare. But if you haven't made those investments yet, you're only going to lose money.
The specifics of some of these specific initiatives and how they align with the existing efforts. Can you speak to some of that? Maybe we don't have to go into all details. One of the things I saw, there was the data network, as well as Kill the Clipboard, which I'm very familiar with Kill the Clipboard efforts, because I've always said that's like one of the most wild things that every doctor's office you go to, you still see a clipboard hanging on a string usually. And like I gave that picture, I think I shared it with people. Like they put a sign on a kiosk, which probably cost like $1 million, that like, do not use. And then there's a clipboard hanging. And this is like, major health system. That's probably one of the top 10, top 15 health system. So let alone what happens at your neighborhood, small doctor's office, right? So like, can you dive in a little bit deeper into these categories, I guess, of the companies that have signed pledges, and what does that really mean for?
Yeah. I'm just pulling up my little cheat sheet on it. So, I mean, there are a bunch of different categories that companies are invited, even today. It's not a one and done. Like anyone can participate if you fit in one of these categories and feel that you can meet the commitments to showcase the application, the user experience for Kill the Clipboard, conversational AI, or using personal information to drive better experiences for diabetes and obesity prevention programs. So those are the use cases. But you first have to get to the data. And so at the top of the funnel, if you will, are who wants to sign up for being a CMS aligned network. And then it's the data sources, right? So that's infrastructure, that's architecture. And then there are data sources. So you can also be a healthcare provider. You can be an EHR vendor because they are systems of record, or you can be a payer. And so if you start looking through those various lenses, I mean, let's just start with the CMS aligned network and why this is a really big deal and what some of the key pieces are. And actually, I'm going to back up and say the other big piece is where CMS is making commitments in terms of building public infrastructure. Because I really think I'm going to start there, because they're committing. They've already announced that they were providing updates on how they're thinking about a national healthcare directory. Everyone knows provider directories are mandated, must be published, and also that they're really bad. I mean, I think you've had Ron Irwangzi on.
Yeah.
So he's told you how bad it is. He's got the receipts. But it's a cost center to maintain those. And then independently of that, we have all these other reasons why we need to have program integrity around providers that can be credentialed because they don't have disciplinary actions. They do have up-to-date licensure in which states, et cetera. But we need to, and we have a really poor NPES right now. It's a directory that doesn't have a lot of integrity. So building a national healthcare directory is a CMS pledge to build public infrastructure that will serve a multitude of application services and solutions. Number one, it's going to massively streamline the validation of basic information on a doctor at the N of one, or practitioners. And since practitioners may see patients at sites, care sites and settings that will go across organizations, being able to then understand where they're seeing patients, and then being able to have all of that trusted through modern infrastructure methods where, our friend Imran Qureshi is much more, is a better expert to describe all that, but would ultimately also put in everybody's digital endpoints. So I said, Dr. Appenfeller, he sees patients at Providence and at Anchor and at all these other places. Sorry to Dr. Appenfeller. But I always think about that. Like, you need to be able to resolve where they see patients and where the digital endpoints are, so those patients can now pull data from the visits that they had based on where they had care. So I think that's a huge step, and it's actually going to drive administrative costs out of the system. We operate in an environment of third-party insurance, right? But the insurance companies are allowed to earn a profit and to cover their overhead. If we can reduce that overhead, we can start bringing down premiums, and we do need more affordable care. So that's just one example. But then on the data aligned network side of things, they're saying modern technology includes modern identity. So we're going to do modern identity. That's identity verification the same way you go through TSA, right? You have a selfie. It's resolved to using a government issued ID, right? That's why they actually they, meaning CMS, announced that FHIR was going to be its first CMS approved identity credential. But while I haven't seen all of the details, I do have a sense from others I talked to in the industry that we're going to see a forward enough looking set of policymakers that recognize that mobile driver's license is already happening in some states and is going to grow. And so if that has equal integrity, then you use your biometric to open your device, that authenticates you, and then you share your credentials from a verified digital identity, mobile driver's license, or through FHIR or whoever. And that should open the doors for you to do what you want. So then the next big thing is patient consented data exchange. Like, give patients true interoperability and control. I won't belabor that because I think that we can always dive in more. But then the next piece is no dark data flows. Let's have these networks have architecture on cloud. Modern architecture has traceability, has visibility, auditability. Like, we have that ability. We should be implementing it at scale. And so the thing is, I think, you've got a whole group of folks that have signed up for it. What we're going to see shaken out is who's already been making those investments and are the leaders versus those who are the laggards. And that's going back to Brendan Keeler. I was like, that's the market, baby.
Yeah, absolutely. Please, those that are interested, check out my discussion with Brendan and Jason Colatonga on we dove into this concept of plaid as they have it in the banking industry, and like, how do we get there in healthcare? Like, funny enough, I think this is actually in some way, this is like, how do you get this, realized network where all of these kind of participants in the network can utilize and supported by all of these technologies that are like, ubiquitous now. Like, you use your iPhone Face ID multiple times a day, right? Like, you're using this technology in everyday life. For some reason, healthcare has been left kind of on the sidelines. I think what I would just say it's Brendan Keeler loves to say, like, it's more fun when we're disagreeing, more have like a contrarian viewpoint, is that like people are maybe worried because of things that are, I'm not going to get into the politics, but there are certain things with this administration and others where certain, companies and certain participants get preferential treatment, or there could be like misuse of data for, certain areas where people have concerns about, be it, I don't know if you heard about this Medicaid data that was released to ICE and all those other things that I think would be an area of concern for people when they hear about this is an initiative that is sponsored by, the White House and all the other stuff, which is obviously we're not going to get into the politics of it, but just to kind of present some of those concerns to you.
Yeah, I mean, I think that it was the mainstream media that really wanted to get their fresh take out very quickly. And they didn't bother to understand or talk to the experts that have been at this for a long time. And so there was just a sloppy assumption that this is getting the support of private industry to help build a government database for surveillance of patients on their health data. It couldn't be further off the mark, right? Full stop.
Yeah, and like when I read the whole framework, like, I'm not getting that. Like, I don't think I'm like off the bat. I think it's the association and like the photo op of, people in the White House and are very close to when we've seen what else has been going on. But like, yeah, I agree. I don't think I'm getting that take from it. But moving on to
the other thing around privacy. Yeah. And I did write an article about this last week, which is, we've been working on this. A lot of us have been working on the privacy side of things for a long time. And at the same time, just remember, HIPAA set a floor. It was a groundbreaking law for consumer privacy, as well as for trusted exchange for permitted treatment, payment, and healthcare operations purposes. But it was the first law in the U.S. that actually recognized affirmative rights of individuals with respect to their data and requesting corrections, et cetera. It didn't go far, right? It was incremental. In the intervening period, we have seen cloud computing, and we have seen, things like the California Consumer Privacy Act. And now I think it's now about 20 different states that have comprehensive consumer privacy laws. The floor has risen effectively. And some might not think about this, but if you're going to be using an app and you're going to try to distribute it widely, you're going to do it on the Apple App Store and the Google Play Store. And both of them have developer policies that are very stringent around patient privacy, especially on sensitive data, including health data. So there are all sorts of ways in which we have layered on a series of different privacy frameworks, both by law or by industry practice, or through voluntary codes of conduct, like the Karen Alliance Code of Conduct, which was first published right after the Cures Act was passed. So there are, and I predict, while it hasn't really come out, but CMS said that they're going to be creating an app gallery for Medicare, for the Medicare Blue Button 2.0. So if you're going to be pulling data down through an application, through these CMS aligned networks, there will be a gallery of apps. And I wouldn't be surprised if there are either minimum privacy commitments that must be made, or it's very transparent what the data practices are for those apps, so people can pick and choose.
Anything else, Jill, you want to chat about or bring up?
The most important thing is that this is not an exclusive club, right? This is really, it's a movement. This administration had had to select some levers. Are we going to do regulatory mandates? Well, you have to go through formal rulemaking. We can just go our own way and show people how. And that's, there's precedent for this. But this was just something a little bit bolder, which is to say, well, let's just try to build a movement. And it is unleashing a lot of that sort of creative energy. If we go back to how we started in this conversation around getting into consulting and the energy that comes from starting up your own consulting practice and trying to help people get to the next level. I mean, I think all of us are kind of in a really interesting space to be able to do that generative work right now. And it's not a pivot away from anything we've done other than what we've promised ourselves on that roadmap. We've been on a roadmap towards interoperability for a long time. We're just going to accelerate the part that's built on modern technology and standards.
Yeah, it's exciting where we get to. So 2026, there is a date somewhat. Again, it's not mandated, but there is like a time frame and there is a timeline where the CMS aligned networks will be, I guess the participants will have to be live by a certain date.
Yes. Yeah. So there's the first objective, which is before year end, to showcase. It's like, think of MVP. We want to minimally showcase the 3 patient use cases for diabetes and obesity prevention, conversational AI, and kill the clipboard. Wouldn't necessarily be at scale, it's just proof of concept, but try to get that done before year end. But for the, and also for all of the CMS aligned networks to be live and in production against criteria that still must be fully fleshed out. We only know some of those that I think I talked about earlier in the broadcast, but you must be live by July 4th, 2026. A lot of roadmaps are in the process of being blown up in order to meet that deadline if your company has signed the pledge.
But if you, let's say you don't meet that deadline, then you just lose. What is the stick? Is it you just lose the CMS aligned badge?
I think it's a combination of, wow, that's really embarrassing. And right. But it's like leaders or laggards. There are companies that are going to be able to be successful, right? Because of investments they have already made versus, investments that they've deferred, relying instead on legacy architecture. So
and this is open, so like anybody can join. Let's say I start my vibe coding app, I can go in and I can sign up. And is there a minimum, what is the minimum? You have to be an actual company with a product and customers and things like that to sign up?
I haven't seen anything along those lines. So the next steps are that all of this will be transparent. All the documentation will be published on a GitHub. And so and it's just like with Fasten, and Be Well, we have a GitHub location too. So documentation will be accessible, right? And so people can make that decision. They can do, and I predict we'll start seeing even more companies that have natively modern technologies are going to join up and become data networks, CMS aligned networks, right?
CMS aligned data network, just so I understand that, and for the listeners a little bit, because that's, I think it's a little bit of a new term that is aligned with like what you would consider, it's not a TEFCA 2.0. It's almost like a patient access network. Here's the data that you have. You're pledged to share it with other organizations. Like, am I reading it right?
Yeah, and I think the a critical difference between TEFCA and this is I call it like you can have in CMS's world special purpose network vehicles, right? BeWell is more focused on consumer consented interoperability. So we have that large network of access points so that you can, a consumer with their consent can pull that data through and then choose how it will be shared with other applications and for other permitted uses downstream. Others have invested historically in, B2B exchange for treatment purposes. And that's where a lot of the networks are. TEFCA requires that baseline so that there's an expectation of all to be a QHIN, to be a qualified HIN that's participating in that top of the spoke or top of the umbrella kind of exchange must minimally be able to support treatment-based exchange, individual access services, which they don't because it's not enforced, and no healthcare operations or payment. Here, I forgot one of the critical categories of pledgees, value-based organizations, the Arcadias of the world, Wellvana and others. They will be allowed to pull, not for all healthcare operations under HIPAA, but for purposes of supporting, it's like a narrower set of data resources in order to support population health use cases. Again, to support value, performance-based delivery, right? And ultimately, good reporting against those quality measures. So I think it's actually a really interesting way in which, so BeWell, we would be committing to supporting interoperability based on consumer consent preferences for anyone that's on our network. Epic will be doing the same for the constituents on their network. Commonwealth will be doing the same for those on their network. There are so many different flavors, but the idea is that if you have someone on your network, you will be supporting FHIR-based interoperability, which is going to give us the kind of scalable coverage and reliability that we need to drive some of these, just to drive some of the crisis issues that the top leadership at HHS is talking about, and which you said at the beginning. It's like, no one disagrees that we have to solve this freight train of a problem.
Right. Okay, wonderful. Thank you, Jill, for your time. And again, just love talking to you about this stuff. I don't know why, but that's like, I think your passion about solving these problems is self-evident, right? And so I really enjoyed this conversation and hope our listeners do as well. And maybe it's one of many in the future occasionally, because I know you're a busy person. Thank you. Thank you, Jill.
This has been great. Thank you so much. And thanks for putting this podcast together. It's great for our community.
Thank you.